Thank you for inviting me again to speak at this great event. I do want to reiterate there is a lot of overlap. You'll see that in some of the slides. There's a lot of information overlap in our clinics. When you see us, when you see Dr. Kirkwood, see me, there's a lot of repetitive talk. But I am nowhere near as smart as him, so I hope I don't have to dose chemotherapy, and I pray he never has to touch a knife. Because again, what he was saying about the Coco Chanel stuff, before the 50s or 40s, a tan was something that was only seen in the working class. So the darker you were, the lower class you were, right? Because you were the ones out in the fields, where the people who were up in the house were pale. So it was only when Coco Chanel turned around and said, hey, look, a tan is sexy, and they made models tan, did people say, I want to be like them, I want to be like the Kardashians, and run out there and get a tan, and that's when we really started to see an increase in the melanoma rates. So I'm going to touch base on what role I have in helping Dr. Kirkwood fight melanoma and helping you fight melanoma. So the goals of surgery are histologic confirmation that a lesion is truly a melanoma. So somebody had asked about, what moles need to be biopsied and things like that. And 60% of them are patient or wife or spouse identified. And it is, I can't tell you how many times a patient has said to me, look, I was worried about this lesion. I showed it to my dermatologist. He said, nah, it looks fine. 6 months later, I went back and I said, look, I'm really worried about this. So you have to kind of force sometimes the dermatologist to biopsy something that you've identified as bad, because they see it every once in a while, but you're seeing it frequently and you're seeing the change and you're concerned about it. So I do encourage people to push their dermatologists into biopsying things. Not biopsying everything, but biopsying the concerning things. And there's data to support that married men live longer than single men. Why? Because the wife is standing there going, you gotta get that taken care of. So you really have to be your own advocate for melanoma. So what I wanna do is help you figure out that this is truly melanoma. I want to help you figure out what stage of melanoma. I'll go through some of the staging, just like Dr. Kirkwood. I want to decrease the chance that it's going to come back at that site. I want to take it off, but still leave you looking good. And I want to help figure out who's at the highest risk for recurrence, so that I can get you onto the trials that Dr. Kirkwood has to decrease your chance of recurrence. So again, the ABCDEs, but it's your own concern, it's evolution. So he had touched base on that. So when you have a lesion, what do you do? What does the dermatologist do, or what does your primary care physician do? Is biopsy it. There's a couple of different ways to biopsy these lesions. The best way to biopsy it is to excise it completely. Unfortunately, dermatologists see so many lesions, and the overwhelming vast majority of these lesions are not melanoma, so they do these shave biopsies. But as you can see from us and from staging, we really need to know the depth of that tumor to tell you the risk that this is going to spread. And sometimes when they shave it, they cut it in half, they don't get the margin, the deep margin, and we can't necessarily tell you what the depth of it is. So we have to treat you as if it was deeper, just to make sure that we accurately stage you. So the best way is to excise it with a 1 to 2 millimeter margin, get below what you think is the tumor, which means get down to the fat. And then do the biopsy in a way that when I come back to get a wider margin, I can keep it cosmetically nice, and I can keep it functional, especially in the extremity or over a joint. If the lesion is too big, then we suggest a punch biopsy, which is a circular razor, and we're able to just kind of cork out a little piece. We prefer it at the junction between the tumor and the primary skin, so that we could tell what the normal skin looks like, and we can confirm that this is melanoma and give us an estimated depth of the tumor. So they send that piece of tissue off to the pathologist, and the pathologist sends you back this big long list. It's multiple pages, lots of big words. But as a surgeon, we like to slim it down to the 4 or 5 things that we really need to know how we're going to treat you. So what do we need to know? We need to know, is this melanoma or not? We need to know the depth of the melanoma. If it's a really, really thin melanoma, all we have to do is excise it and you're done. If it's a really, really thick melanoma, then that puts you at higher risk for spread. Is it ulcerated? Meaning, has the layer of skin over the top of those melanocytes broken? And if it has, then it's telling us that this is growing a little bit more rapidly, and rapid growth tells us that there's a higher likelihood that this is angry and can spread. And then, is there active cells dividing? If there's active cells dividing, it also gives us an idea that this is something that can spread quickly. So the staging is based on those things that we just talked about, the depth of the tumor and whether or not it's ulcerated. So the deeper the tumor goes, the higher the stage. So stage 1A and 1B is based on depth. So 2 millimeters or less, or 1 millimeter or less with ulceration. Stage 2A, 2B, 2C is all based on depth. Again, it's from 2 millimeters to 4 millimeters, plus or minus ulceration. Stage 1 and stage 2 are localized to the skin, and after full evaluation without any evidence of lymph node spread or metastatic spread. Treatment for just stage 1 and stage 2 is, for any primary melanoma of the skin, is a wide local excision. So it's a definitive surgical treatment of the cutaneous melanoma. We need to get wide enough margins that we could tell you that the likelihood of recurrence of this tumor at that site is low single digits. And we need to go all the way down through the fat, down to the muscle layer. We don't have to take the muscle, we don't have to take the fascia or the strength layer around the muscle, but we have to take all of that fat because that's where the lymphatics are. And if this is a deep growing tumor, we want to make sure that we get underneath it and around it. We'd like to do one wide local excision. I don't want to go in, do a wide local excision, find a positive margin, and have to take you back. This should be a one and done thing. Luckily, over the last 20 to 30 years, there's been tons of trials looking at how wide I have to go. Back in early surgery, 50, 60 years ago, surgeons always thought wider was always better. More is always better. So when we're going to resect something, if you go wider, you're really going to help somebody. But we learned from the breast cancer data that just because we take more and we mutilate people doesn't necessarily mean that we're decreasing recurrence or helping them survive longer. So what we looked at was meaning surgical societies, looked at width of resection. We used to do very, very wide resections, and we have to do big flap closures that made people, have less cosmetic outcomes. And skin graft was really, we used to get 5 centimeter margins on tumors. So if you get a 5 centimeter margin, it's 10 centimeters plus the width of the tumor. So you were taking huge pieces of tissue off of people, and it didn't necessarily make them live any longer, but it definitely mutilated them, and it wasn't cosmetically nice. The nice thing that we do now is we're able to get people closed in a straight line with minimal flaps, and we don't have higher risk of local recurrences. So for thin melanomas up to 2 millimeters in thickness is what we consider thin. But how I talk to my residents and when I'm teaching them is 1 millimeter tumors or less get 1 centimeter margins. 2 millimeter tumors or greater get 2 centimeter margins. Somewhere between 1 millimeter in depth and 2 millimeter in depth gets 1 to 2 centimeter margins depending on cosmetic outcome. So if it's on an area that you have a lot of extra skin, get 2 centimeter margins. If it's on an area where you don't have a lot of skin, on the face, on the shin, on the foot, where it's very hard to get it back together, you can go back towards 1 centimeter margins because the increased risk of local recurrence is only 1 to 3%. So in those areas, you don't have to go wide just because somebody told you you have to. You could err back towards 1 centimeter margins. But they looked at 2 centimeter, and for 2 millimeters in thickness and less, they looked at 2 centimeter margins versus 5 centimeter margins, and 2 centimeter margins were equal in local recurrence. They looked at 1 centimeter margins versus 3 centimeter margins, and 1 centimeter margins were adequate in 1 millimeter in depth tumors. And they did that also for intermediate and thick melanomas. You would think that the thick melanomas, it would be better to go wider, but the limiting factor in people with really, really thick melanomas is metastatic disease. And since it's so deep, there's a much higher likelihood of metastatic disease already. So just to go wider isn't necessarily going to stop there from being metastatic disease already. So regional lymph node status. So resection of the primary lesion usually controls the local area. But how do we know if it's spread? So melanoma often spreads via the lymphatics. And we need to assess those lymph nodes to get an accurate staging. Lymph node involvement, for us to feel the lymph node, if we don't feel a lymph node, 20% of the time, there's microscopic disease in that lymph node. If we do feel a lymph node, 20% of the time, it's false positive, meaning I feel it, we take it out, and it's got no cancer cells in it. So physical examination is not accurate. For the other thing that we need to know lymph node status is to know whether or not you're at a higher risk of recurrence and whether or not you'll be somebody who might benefit from adjuvant therapy. Dr. Kirkwood had talked about there's now 13 different types of therapies on the market, and 3 or 4 of those are approved for the adjuvant treatment of melanoma, meaning you have no evidence of disease, but we're going to give you a medicine to decrease the likelihood of this coming back. And those are the people that we really want to find. If you already have intermediate thickness melanoma and you have a high risk of recurrence, how do we decrease your risk of recurrence? So stage 3 disease, so stage 1 and 2 disease is localized to the skin. Stage 3 disease has already spread to the lymph nodes. Stage 4 disease is distant metastatic disease. We could break down survival data into many, many curves, right? We could look at just T staging, or the depth of the tumor. Obviously, the deeper you go, the more likely it has a chance to spread. Your overall survival decreases. Lymph node status. The more lymph nodes you have, the more likely you have a chance to spread, the decrease in your overall survival. And then we can change it, we can look at it in stages. Stage 1A versus stage 2C, stage 3A versus 3C. So we know that the higher stage, the more likely this disease is going to come back. Overall survival, again, Dr. Kirkwood had shown this slide. So how do we go get that lymph node? How do we figure out what that lymph node is? Well, back in the 70s, we had no idea how to go get that lymph node. So we used to take people who had what we considered high-risk melanoma, and some of them would go to the operating room, we'd make an incision, and we'd take out a bunch of lymph nodes. Again, this is kind of a mutilating surgery in people who we don't know if they're going to be positive or negative, and in a good amount of the time, these lymph node dissections were negative. And maybe a person had complications from the surgery or a swollen extremity. So Don Morton and his group out in California said, well, we can't just continue to mutilate people. We need to find a better way to figure out which lymph node is draining this area. We have very specific highways that drain each area of our body. So if we could figure out that highway and we could figure out which lymph node drains this area, then we can go get that one specific lymph node, and if that lymph node is negative, we hope that the remaining lymph nodes that are left behind are negative. So what they did was they started to inject blue dye around the tumor site, and then they would go into the lymph node basin that they thought it drained from, and they would look for a blue lymph node. We've gotten better over time, and we've started to use radioactive dye as well, which we can image before you have your surgery, and it gives me a roadmap to where it goes. So I'm not just randomly choosing a lymph node basin, I'm going based on a roadmap that the radiologist has given me and said, it's in this lymph node basin, go find this radioactive lymph node. But in the original data, what they found was 75 to 90% of the cases, they were able to identify that lymph node. And then right after they went and got that sentinel lymph node, they completed the dissection. So they had the sentinel lymph node and they had all the background lymph nodes as well. And in only 1 to 2% of those cases was the sentinel lymph node negative, but the background lymph nodes positive. So they validated this technique. We can go and get these 1 or 2 or 3 sentinel lymph nodes and leave the remaining 12, 14, 16 lymph nodes behind. It's a minor surgery, but we can get accurate staging. Now we identified 97 to 98% of lymph nodes. Just like anything, we're better over time at doing procedures. So now it's incredibly rare that a patient presents for a sentinel lymph node biopsy and we can't find the lymph node. So what's the likelihood of detecting metastatic disease? So we really use the rule of tens to counsel patients. So it's 10 times the depth of your tumor. So if you have 2.5 millimeter depth melanoma, we multiply that by 10 and say you have about a 25% chance that that lymph node is positive. There's been many meetings about, do we do this on everybody? Do we only do this on a few people? How do we choose who to do this on? So in a lot of medicine, it's the 10% rule. If the risk of you having metastatic disease is higher than 10%, then those are the patients that we want to go looking. If your risk of having metastatic disease is lower than 10%, then the risk of the surgery outweighs the risk of you having melanoma. So if you have a 0.2 millimeter depth melanoma, you have a 2% chance of having a lymph node positive disease. It's a much higher risk of having a complication from surgery, so we don't go looking. So usually anything less than 1 millimeter in depth, or if you are less but have more worrisome features like ulceration or mitoses, those are the patients that we want to go looking. They looked at overall disease-free survival at 5 years. Patients that have sentinel lymph node negative disease, it's almost a 85% 5-year survival. But it's only a 53% 5-year survival for sentinel lymph node positive disease. So it's a dramatic change in your overall survival. And again, those are the patients that we want to try and treat proactively with adjuvant therapies. So a melanoma-specific 5-year mortality, about 10% for sentinel lymph node negative, about 26% for sentinel lymph node positive patients. Sentinel lymph node biopsy positivity is the single most important factor predicting melanoma recurrence. Now, there was a hint earlier, and some people, we would believe that it's a stepwise progression. Melanoma goes to lymph node goes elsewhere. But here in Pittsburgh, with the NSABP trials on breast cancer, we really think of these things more as systemic disease when it starts. So if a cancer is going to spread, it's likely spread from when we identify it. So the sentinel lymph node positivity is just an indicator that the tumor has spread, not that if we keep going wider, we're going to get ahead of this disease. So we just use it as a prognostic indicator. So this is the roadmap that I get from radiology. So this is a mid-chest melanoma. So they inject the mid-chest melanoma with radioactive dye. They wait an hour. They do a lymphoscintigraphy, and you can see that it tracts along the lymphatics to the left axilla and the right axilla. So this patient needs a sentinel lymph node biopsy of these 2 lymph nodes in the left and this 1 lymph node in the right. The patient comes up to the operating room. I use this Geiger counter, but they call it a Neoprobe, so they could make it 10 times more expensive than a regular Geiger counter. And then I use that to find the radioactivity. I make a small incision in somebody's armpit. I go in and I take out that lymph node. That procedure itself usually takes me about 45 minutes to an hour. And then I have to take off the primary melanoma as well, so it usually takes me about an hour and a half. So again, the Society of Surgical Oncology and the American College of Surgical, the American Society of Clinical Oncologists got together and you don't get medical oncologists and surgical oncologists in one room very frequently. But they came up with these guidelines. So like I had said, 1 millimeter in depth or greater, or if you have high risk features in something that's less than 1 millimeter in depth. So that was my talk that I had given over the last few years, but I wanted to add something this year because I think Dr. Kirkwood can also attest to this. Because they have new therapies for melanoma, what we're finding is more patients that seem to have resectable metastatic disease, or patients that have metastatic disease that it seems more logical to go in and resect. So with some of these therapies that Dr. Kirkwood and Dr. Tarhini are giving patients, we're seeing patients with 8 metastatic deposits, 7 of them are controlled, and 1 of them is growing. Well, if those 7 are controlled, why wouldn't we want to go get the one that's growing on this therapy and see if we can get that patient back onto their therapy quickly, and that they can continue to have the remaining disease controlled. So I wanted to look back over some of the data that we have for resecting metastatic disease in melanoma. So traditional thinking was, once melanoma has spread, trying to take out a metastatic deposit doesn't necessarily make any sense, unless it was causing severe symptoms. But over the last 20 years, Dr. Kirkwood and his group have gotten better at treating with medically, systemically, and surgeons, we've gotten better at being able to get people in and out of the operating room with minimal incisions, laparoscopic, quick recovery on anesthesia, and out of the hospital fast, so less complications from surgery. Up to 80% of people will recur with metastatic melanoma in only 1 organ. And 80% of people will recur with only 1 spot. And 55% of those people will have resectable disease. Why isn't 80% resectable? Well, sometimes it's in the brain, or it's in an area that we can't resect, or people are too sick with other medical comorbidities for us to resect it. But up to 55% of patients will have a resectable metastatic melanoma. There was one of the largest trials that we had done, which is the MSLT1 data. They did a subset analysis looking at, of the 2,001 patients enrolled in the original trial, they looked at the 291 patients who developed distant metastatic disease with detailed records that they could see what happened after they were identified to have metastatic disease. And what they were able to show was that if you add surgery to best systemic therapy, that there is an overall increase in overall median survival and an increase in your overall 4-year survival in patients with metastatic disease of melanoma. So there is a role for surgical resection of metastatic disease in the selected patient, and I think that role is going to increase over time now that they have better immunologic and targeted therapies that you're about to hear about from Dr. Zroor and Dr. Tarhini. So I'd like to, so in summary, so if you have a worrisome lesion, if you're worried about it, make your dermatologist or primary care physician worried about it. Don't just accept that they say, it's okay, and move on. You have to kind of sometimes force their hand into biopsying it. Always biopsy things for diagnosis. Margins, we talked about, if a sentinel lymph node is positive, then we go out and take the remaining lymph nodes to get adequate staging. And then being in an institution that has a multidisciplinary approach to metastatic melanoma will improve your outcomes from these advanced diseases. So we encourage people that are at small community facilities to come here for at least a consultation so that we can give you the best, most up-to-date treatment plan. And there is a role for surgical management in metastatic melanoma in selected cases. Thank you very much.